Recently, several internationally prominent neurologists participated in an evidence-based review of the efficacy and safety of natural products for migraine at a CME conference in Los Angeles, California. The meeting was chaired by Dr. Richard Lipton, who discussed the efficacy of natural products for migraine. Why focus on natural products?
50% of people with migraine use natural products, and for natural products sometimes in conjunction with other agents. So let me take a second to talk about complementary and alternative medicine. And these definitions, which are borrowed from the NCAM, the National Complementary and Alternative Medicine, NIH branch, drive me slightly crazy because they're so circular. But complementary and alternative medicine is defined as healthcare systems, practices, and products that are not part of conventional medicine. And conventional medicine is defined as what people with MDs and DOs do. So these are incredibly socially normative definitions. And since I think many headache specialists use natural products, by this definition, they may or may not be considered as complementary and alternative. According to the National Center for Complementary and Alternative Medicine, there are 5 areas to be considered. One is biologically based practices, which are herbs, supplements, aromatherapy, and that's what we'll be talking about today. Just to set the stage for thinking about how to incorporate natural products into practice, epidemiologists believe that absolutely everything in life can be summarized in 2x2 tables. And that's a belief that I'm so invested in. No matter where I stand, I can't get out of it. But so the issue, so I believe that both for conventional and complementary medicine, it's really about what's proven to be safe, what's proven to be effective, and what's the risk-benefit in an individual patient. So if a conventional medicine or a complementary treatment is safe and effective, then of course it makes abundant sense to use it. If a treatment is not safe and not effective, it's perfectly obvious that we shouldn't use it. And then if a treatment is not effective but is perfectly safe, personally, if we actually know that, my approach is to comment on the lack of evidence and to tolerate those treatments. And if a treatment is effective but not safe, then obviously we need to do a risk-benefit analysis. And I would submit to you that whether we're thinking about a drug made by Big Pharma or a natural product, this is the most reasonable framework for thinking about it. So focusing on complementary and alternative medicine is worthwhile, in part because 40% of adults in the US use complementary and alternative medicine. And this is a paper by Dr. Wells that was published in 2011. CAM is used more commonly in people with migraine or severe headache than in those who don't have it, and this is a study that provides a 50% number of patients with migraine and severe headache who use CAM. Almost half don't discuss those options with their doctors, and obviously since use is so high, I think it behooves us not to just say, well, what are you taking for your headache, but to say, are you taking any complementary and alternative treatments, any medicines, any herbs, any other practices? And the biologically based natural products are the most widely used form of complementary and alternative medicine, and really the ones where evidence is most solid other than for behavioral interventions, and so that's why we're focusing on it today. So with that, I'm going to move on and discuss with you efficacy of natural products. So the evidence for complementary and alternative medicine was fairly recently reviewed by the American Academy of Neurology, and they published a guideline addressing these issues. And I'm going to rely pretty heavily on the guideline for this review. So the guideline was published in 2012. As you know, the Academy method divides the evidence for, rather classifies studies at 4 levels. So a class 1 study is a randomized controlled blinded study with clear primary outcomes, eligibility criteria, and accounting for dropouts, and essentially a design which takes the traditional measures to protect against bias. A class 2 study is a blinded randomized trial that has a single flaw. A class 3 study, or as any other controlled study, including those that use historical controls, and class 4 studies or other studies. So I'm really only going to focus on the higher levels of evidence, since in a condition with high placebo rates, other sorts of evidence is hard to interpret. And then based on the studies, the Academy classifies treatments as having level A evidence, meaning established efficacy, level B evidence, meaning probable efficacy, and level C evidence, meaning possible efficacy. So the only, of the natural products, the only one that has class A evidence is Petasides or Butterbur. MAG, feverfew, riboflavin, and histamine are classified as having level B evidence, CoQ10 as having level C evidence, and I'm just going to briefly review that evidence now. So the way I'm going to present it is I will present what I consider to be the higher quality studies for each drug. I'm going to summarize the endpoints, and we're going to look at reduction in headache or migraine days from baseline for the active treatment and placebo. And then I'm going to show you the absolute reduction in headache days across a range of products. I'm going to, when it's available, report the 50% responder rate and number needed to treat. And just to remind you, number needed to treat is 1 over the responder rate for active drug minus the responder rate for placebo. So if 100% of people respond to the active drug and 50% respond to placebo in a particular study, the number needed to treat would be 2. And the way to think about number needed to treat is how many patients would you need to treat with the active drug to help somebody above and beyond the effect that you see with placebo. In many ways, NNT is not I don't find NNT particularly useful for acute treatment. I think it's useful for preventive treatments, which we're focusing on, and extremely useful when we're doing aggressive interventions that prevent things like death or heart attack or stroke. But in this context, I think it's a reasonable summary. So starting with Butterbur or Petasides, it's an extract of the root of the Butterbur plant, which is in the daisy family. That is what Butterbur looks like. It's been used in folk medicine for cough, rhinitis, and headache for hundreds of years. It contains petacines. There are 2 studies that were judged to be level 1 studies. The first is a Diener study where he compared placebo with Butterbur 50 BID. And just to get you used to the format here, what we're looking at is the arm of the study, placebo versus Butterbur, the reduction in headache or migraine days to placebo to active drug, and then the difference between the 2. And then we're looking at responder rates, which we use to compute risk reduction. So this reduction of 1.3 headache days per month, is quite reasonable, statistically significant. In the second study, which is a study that I led that was also published in 2004, we looked at Butterbur 50 BID and actually at also 50 TID. The absolute risk reduction was similar in magnitude to the one in the Diener study for the 75 milligram dose, but not for the 50 milligram dose. And the 50 BID dose was not statistically significant in my study, though certainly trended in that direction. And the number needed to treat was somewhat higher for Butterbur in the US study. But it's these two studies that are the basis of the AAN classification of pedicides as having class 1 evidence. Now, this is a little bit unfair, and I'm certainly not suggesting that pedicides is as effective as topiramate, but just to provide a frame of reference, I picked one of the topiramate pivotal studies to show you that, with topiramate, the reduction in days is, 1.3 days per month, and the NNT is 3.2. And again, the patient populations are very different in these studies, so results aren't comparable. My point only is that the range of response is not tremendously different for a natural product and for a prescription drug we judge to be highly effective. So moving on to feverfew, it is a member of the DAISY family also. It's traditionally been used for pain, fever, arthritis, menstrual irregularities. In the 80s, it became a tremendously popular treatment in the UK. It has a variety of active ingredients. There was a Cochrane review in 2004 that included 5 trials and 343 patients. And the Cochrane review base of those studies concluded that efficacy was not established. Chris, being a huge contributor to this area, actually, again, did another study of feverfew using a CO2 extracted formulation and demonstrated statistically significant benefits for feverfew. The evidence for feverfew is mixed. This is certainly a good study, though I actually couldn't find the responder rates in the paper. If they're there, Chris, correct me. So riboflavin, or vitamin B2, is involved in mitochondrial electron transport. It's a cofactor in the Krebs cycle. The therapeutic dose for riboflavin is enormous relative to the minimal daily adult requirements for riboflavin. When we look at efficacy, there are 3 studies that I selected here, although in fact there are a lot more. The study that's the basis of the Academy recommendation is the Jean Chernin study that was published in Neurology in 1998. He randomized 55 patients. They got placebo or riboflavin. The magnitude of the reduction in headache days is large. The NNT is small. The difference in responder rates is actually quite impressive. And these other 2 studies that I listed here are negative studies, one in 48, both of which are in children. Now, I actually personally use riboflavin in kids quite frequently because, it's very safe and possibly effective. So for magnesium levels are reduced in serum and blood and saliva and CSF, and probably in the brains of people with migraine. Peter will tell you more about the mechanisms of migraine. When it comes to assessing the efficacy of migraine, this first study is the positive one. The change in headache days is about 0.9. The NNT is about 4. The responder rate is 56% to active drug, 31% to placebo. And to provide a context, there's a study in kids and a study in adults which were entirely negative. So again, MAG has some evidence for efficacy, and the AN considers it probably effective. For CoQ10, there are few double-blind studies. There's an open-label study by Rosen that suggested efficacy. Perhaps the best of the studies is one that Peter Sandor did that was published in Neurology in 2005. He randomized 42 adults to placebo or 100 of CoQ10 TID. Again, we're seeing a reduction in headache days of about 1 and a number needed to treat of about 2.9. This contrasts with a negative crossover study in children and adolescents. So an intriguing acute alternative treatment for migraine is this sublingual feverfew and ginger product. This is a lipid-based formulation of feverfew and ginger. Patients with migraine, take it orally, and there was a single randomized trial done by Roger Cady where he had 59 patients treat 221 attacks. And I'm showing you here for active drug and placebo the 2-hour pain-free rates, 32% versus 16%, and the 2-hour headache response rate, 64% versus 39%. So this, and actually I think I stated it backwards. This is the pain-free data. This is the headache response data. There was an analytic issue in the study because single individuals treating multiple attacks were treated as if they were multiple individuals treating single attacks, but on reanalysis, the data actually holds up. So this again is the summary from the American Academy of Neurology in a paper by Starholland, Steve Silverstein, Fred Freitag, summarizing the agents that have level A and level B evidence, and we talked already about an approach to thinking about it. I just want to point out that the National Center for Complementary and Alternative Medicine has a pretty robust website, lots of information on a variety of products that have been well studied. And this, again, is a summary of the agents for which we have evidence.
Be sure to watch Part 2, a discussion of the safety of natural products for migraine, and a Q&A session.